Good morning. I am going to present a case of a 61-year-old male resident of Patna, Bihar, who presented to our side with complaints of fever on and off for last 4 months, associated with weight loss of approx 20 kg, and it is also associated with decreased appetite for last 2.5 months. And he presented in our emergency department with a decline in sensorium for last 1 day. He was apparently well 4 months back when he had developed fever. Fever was ranging in the range of 100 to 103 Fahrenheit, intermittent. It was relieved with antipyretic medications. There is history of cough with expectoration. However, there is no history of hemoptysis, no history of burning micturition, abdominal pain, headache, vomiting, seizures, or any focal neurological deficit. It is associated with weight loss of around 20 kg in last 4 months. He has also developed easy fatigability and decreased desire to work. There is a loss of appetite for last 2.5 to 3 months. However, it has increased over last 7 days, and patient is only on liquid diet for last 7 days. There is history of receiving multiple antibiotics, but fever is not resolving. At the day of presentation, he had history of 5 to 6 episodes of loose stool over last 24 hours and with incontinence present. However, there is no blood in stools. Past history, he is a known case of type 2 diabetes mellitus last 10 years. Initially diagnosed in view of tiredness and weight loss. Initial RBS was 240 milligram per deciliter. At present, there is no history of polyuria, polydipsia present, and blood sugar are fairly controlled with fasting less than 150, PP less than 200, on metformin 500 BD. And no history suggestive of microvascular or macrovascular complication. He has developed hypertension for last 2 to 3 years and controlled on telmisartan 40 mg OD. There is no history of any pulmonary tuberculosis in the past, no history of other comorbidities. He is farmer by occupation, no history of addiction, and no relevant family history. On general examination, patient is conscious. However, there is he is not oriented to place, and orientation to time and person is there. And tongue appears to be dry, eye sunken. BP was 140 by 90 millimeter of mercury. Pulse rate is 86. Respiratory rate is 12. GC is E4, V6. Weight is 60 kg. Pallor is there. However, there is no icterus, clubbing, cyanosis, or any peripheral lymphadenopathy. Thyroid is normally palpable. CNS GCS is E4 M6 V4. No cranial nerve deficit is there. Power at the time of admission was 3/5 in shoulder, elbow, hip, and knee joint. And bicep, triceps, knee reflex are 2+. However, ankle reflex could not be elicited. Cardiovascular system S1, S2 present, no murmur. Respiratory system bilateral clear, no added sound. Per abdominal, soft, non-tender, and moderate hepatosplenomegaly is present. On evaluation, he has anemia. Hemoglobin is 10.4. Counts is 7,300. 88 neutrophils. Platelet 2.1. ALP is, there is a hypercalcemia 15.9. Correct. And on correction for hypoalbuminemia, corrected calcium was 16.9. And ALP was 351. Phosphorus is 1.8. HbA1c was 7.3. Urine sugar present, no protein. On further evaluation, vitamin D is 185 nanomole per liter, which is normal in range. PTH is 1.7 picomole per liter. M-band is negative. HI wire marker non-reactive, and EC so QTC of 390 millisecond with normal sinus rhythm. As on investigation, there is hypercalcemia. We took a retrospective history for there is no history of fracture, renal stone, constipation, abdominal pain, or psychosis. No history of polyuria, no history of vitamin D supplementation, no history of prolonged immobility, and no history of hemoptysis. Now, we had with the 125 hydroxy D and ACE levels. 125 hydroxy D was elevated, 131 picogram per ml, and ACE levels were mildly elevated, 87 unit per liter. So we kept a diagnosis of PTH independent hypercalcemia secondary to granulomatous disease with the type 2 diabetes mellitus, fair control, and no evidence of micro or macrovascular complications.
You can ask.
Any question?
No, I think things are pretty clear. I think we can proceed.
So in view of hypercalcemia, we started with IV fluid bolus followed by infusion. Injection calcitonin 200 international unit BD given for 2 days, and he was also provided with injection zoledronic acid 5 mg. And we can see that there is a decline in the calcium levels gradually, and the patient become normocalcemic on after 5 days. We head with the radiology in search of a granulomatous disease. PET CT shows metabolic active cervical, mediastinal, retroperitoneal lymph node, along with metabolically active bilateral bulky adrenals and metabolically active right lower lung changes. We have done CT chest plus abdomen to better characterize the bulky adrenals. It shows bilateral adrenal gland enlargement with heterogeneous patchy and peripheral enhancement with area of necrosis, along with patchy consolidation in bilateral lower lung fields and hepatosplenomegaly with mediastinal and retroperitoneal lymphadenopathy. So we have decided to go with the adrenal biopsy. Before going, here we can see bilateral bulky adrenal glands with area of necrosis and heterogeneity in the lower lung fields. Before going with biopsy, we have done serum cortisol levels, which was 349 nanomole per liter. ACTH was 11.2 picomole per liter, and PRA was less than 0.2 nanogram per ml per hour. We have started patient on injection hydrocodone 25 mg TDS, and injection hydrocodone 100 mg was given just before the biopsy, and biopsy done after giving the injection, and after that he was switched to tapradolone 10 mg and then tapered off over next 10 days. And for sugar management, he was shifted to insulin and continued on basal bol regimen. Biopsy, adrenal biopsy shows it was negative for AFB, and the gene expert also could not detect MTB complex. And biopsy specimen for mycology on KOH mount, there are moderate pus cells with plenty of small budding yeast. Giemsa stain was done, which shows few intracellular small budding yeast cells, which were suggestive of histoplasmosis. Culture was also done, and which came after 2 weeks, and which was also confirmatory of histoplasmosis. We had also done bone marrow for this patient, which shows cellular marrow with trilineage hematopoiesis with granulomatous inflammation. AFB was negative, a few small capsulated organisms in histoplasmosis. Here we can see KOH mount showing small budding yeast cells. On this bone marrow aspiration stain with Giemsa stain, we can small yeast cells in the engulfed in the macrophages. This is the slide of cultures showing mycelial forms of histoplasmosis, and on magnification we can clearly see the fungus. Further course, he was started on liposomal amphotericin B at 5 mg per kg. Fever subsided after initiating of antifungal therapy, and we continued injectable liposomal amphotericin B for next 14 days. However, it was after 14 days, it is decided to switch the patient on tab itraconazole, but after shifting the patient on itraconazole, there is a patient developed fever again. And after the recurrence of fever, we removed the central line, Foley was removed, counts were done, which were normal. No improvement in fever, so we have sent culture and started the patient on injection ceftriaxone. However, there is no improvement in fever. We take repeat cultures, which were sterile, antibiotic change to meropenem, fever persisting. We then added teicoplanin. Blood cultures were repeated, urine cultures repeated, but no organism isolated. We also have done at the time bronchoalveolar lavage, considering the possibility of co-infection with tuberculosis, which shows AFB negative. We also have done malarial parasite. Procalcitonin was done. At the time of admission, it was 1.9. However, at the time it was 0.2. So it seems that bacterial infections, we have given antibiotics, we have sent cultures, and it seems that bacterial infection and other causes of infection were unlikely. So after consideration and in view of persisting fever, it has been decided that we will give a second course of liposomal amphotericin B, and patient is started on a second course of liposomal amphotericin B. Fever resolved after initiation. Patient was given amphotericin B for another 14 days. After that, he was shifted to itraconazole 200 mg TDS for 3 days, followed by 200 mg BD. During hospitalization, patient also had a history of drop in hemoglobin level along with black tarry stools. As patient was on prophylactic anticoagulation, it was stopped, and in view of melena, patient was endoscopy was done for the patient, which shows non-bleeding ulcer in the duodenum, and there is no active bleed. And CTA abdomen angio has been done, which shows us 10 centimeter long retrophageal hematoma, but there is no active bleeding. And biopsies done were negative for any malignancy or any spiral organism. So patient, it is decided to manage the patient conservatively. Blood transfusion were done and hemoglobin were built. So we come to a final diagnosis of PTH-independent hypercalcemia due to a granulomatous disease with disseminated histoplasmosis with esophageal hematoma with type 2 diabetes mellitus and fair control. At discharge, we discharge the patient on insulin regular 12 unit before breakfast, 10 unit before lunch, and insulin glargine at bedtime with tebuconazole 200 mg BD planned to give for next 1 year. Patient was last followed in April 2024. Patient has improved. There is no recurrence of fever. Appetite has improved. He is gaining weight. Calcium is normal 9.5, phosphorus 3.3, albumin 4.2, ALP 136. Serum cortisol was repeated. It was 348 nanomole per liter. Itraconazole drug levels were done, which shows 0.85 microgram per ml, which is lower than the therapeutic threshold, which is required. So we have increased the dose from 200 BD to 200 TDS. Any questions?
Yeah, so thank you for the presentation. So Nisha was just pointing out this slightly lowish phosphorus in this patient. Was it, did you take it as part of infection?
Infection also, sir, patient has a poor appetite. Also, he's not taking any food for last 7 days. At presentation, that's why we
Yeah, so
lower side.
we didn't do a TMPGFR or anything like that. No, reason I am asking is sometimes there are clues from this thing, meaning, for example, some sarcoidosis is known to have both 125 mediated as well as PTH-RP mediated hypercalcemia. So sometimes, you have this hyperphosphaturia coming up due to sarcoidosis. So that can be a clue to make it. But I suppose in this case, it's just taken as part of the illness itself, meaning some sick situation in which the phosphorus gets transported intracellularly, correct?
We had monitored phosphate after we had started treatment very rigorously because of fear of repeating. So apart from that, first couple of values it was all normal. And this 125 had also come high, so we had thought that 125 mediated hypercalcemia. We suppose the initial phosphate due to poor appetite.
Okay. Thank you. Yeah. Please.
When you have high 125, you are going to have high phosphorus rather than low phosphorus, because that's going to increase the phosphorus absorption from the gut. That's akin to the bottom detoxicity actually. So sarcoidosis is extremely unlikely. Of course, in the preliminary thinking, sarcoidosis was a strong possibility because it is common, and its classical presentation could be any granulomatous disorder, disseminated one. But at 125 axis would not cause hypophosphatemia. That's what I believe physiologically. Yeah.
The high vitamin D, 25 hydroxy vitamin D was high, no? And he has not received it. So it's a cross, it's an assay issue. 185 or something you told, no?
So 125 levels
Was elevated?
how much elevated?
185 nanometer.
What's the normal? 52? Okay, it is almost twice normal.
Actually, another thing you could have thought of, we did think of initially, was that it could be due to adrenal insufficiency. You get hypercalcemia. Hypercalcemia is very well known, both in primary and secondary adrenal insufficiency. But I think the cortisol, I don't know whether that was post-stimulation or whether that was a basic. The initial one was while he was stressed, the 385, which is why we started him on hydrocortisone irrespective.
Then
The-
once we had stabilized, we had repeated it.
But the ACPH also
Oh,
was 11,
was normal.
upper end of normal,
Yes,
na?
and the
So
PR also we had sent.
the PRA was
PRA.
undetectable.
I think that adrenal insufficiency was not there.
Evolving
Oh.
हो सकता है.
Adrenal insufficiency can often cause, and the only thing I will say for this patient is that the patient got zoledronic acid, and he looks like he has a very large load of histoplasmosis, and that if the effect wears off, then you may again have
Hypercalcemia.
calcemia, so you should probably keep on testing for it, monthly, so that there is no recurrence.
If we don't follow up for 6 months now, we lose calcium simply normal person.
Lucky. चलो.
Admitted in December. He was admitted in December and discharged in February, beginning.
Dr. Pabin, how long you give amphotericin B in the disseminated histoplasmosis? Not cerebral, but how long do you give in your experience?
No, sir, our experience is very limited. Most of the patients who had, worked in North or something like that. So, itraconazole, our mainstream treatment is itraconazole. Correct, Nisha? And most of them have responded very well. I think one patient we had given amphotericin for 2 or 3 weeks, initial loading or something. That was long time back. And off late, sir, we don't come across histoplasmosis because I think mostly this migrant workers and all. In Kerala, meaning without any exposure to, going outside the state, I don't think we have seen any case, Nisha. All of them are like that only, sir. So maximum we have given for 2 to 3 weeks only, sir.
Okay.
Ah.
That's a little surprising that you are not getting histoplasmosis because that's a basically normal commensal actually and gets into the system in immunocompromised state. So that looks a little surprising, relation histoplasmosis, because it's not uncommon here. It comes in the first of the few differential diagnoses, rather late in the differential diagnosis. That's a little surprising, and because it's there in the soil all over the place, and pigeon is one story, but but it's there in the soil actually. So a little surprising to see that.
Yes, sir, but
Or your daughter
yeah.
pigeon.
Yeah, so I don't know, sir. Meaning that is what the biopsy tells us. For us, it's the meaning there is no history of going outside. Most of the time, it's tuberculosis.
Lots of these patients are farmers.
Just slightly, kind of theoretical situation. Sometimes we face that. Now, patient with adrenal enlargement, not big enough to be biopsied, and not having other lymph nodes or anything like that, biopsy. In that situation, how do you go about it without biopsy? Is antigen helpful? I suppose you have the literature review coming up. Probably there are some clues in that. Is antigen helpful? Or, otherwise we are left with...
You do the urinary antigen for histoplasma, and actually this is important for diagnosis also, as well as for the follow-up. Like
you can
if
use it
in the idealized-
diagnostically also, not just for follow-up, right?
Yeah,
Yes.
you can use it, but microbiological criteria is very strong. Like you said, you cannot biopsy the adrenal gland, which is mildly enlarged, and you have got clinical context of that. Then one can rely on 24-hour histoplasma antigen. But kits are available internationally, but not in India.
AIMS is.
AIMS doesn't
AIMS
have.
and is.
They do it now?
Yeah.
Okay, so we tried to procure it, but the vendor was not ready to provide because it's all imported. The consumption level is too low actually, so he failed to provide us. But that's available actually. Internationally.
We have also
yes.
done it, sir, as follow-up thing. Some commercial lab was also doing it. I am forgetting whether it was Quest or Quest is out of business now, in India at least, or whether it was Lalpath, I am forgetting. So one of these had the antigen. And we had done it as a follow-up measure, not diagnostically, but this is a problem which we come across. Non-biopsiable lesion without significant other lymph nodes to go around and do FNA or biopsy.
The problem with the treatment of histoplasmosis is practically empirical. There's hardly any RCTs actually.
Sure.
That's and it's more of expert statement or consensus statements by mycology groups. So everything is pretty empirically and if you look at the mortality pattern vis-a-vis drug dosing and duration, that's highly variable. So what the guideline says, what the trial, the retrospective data analysis of large centers, they show little disparity in this thing. So 2 weeks disseminated textbook says was practically does not cross that thing. Similarly for the cerebral also, they say minimum 4 weeks. So let's disparity in the literature actually of giving histoplasma. Of course, once you got bone marrow, you have to give amphotericin B. There is no choice. You cannot bank upon itraconazole.
Naman,
Thank you, sir.
go ahead with your. Praveen, we'll go ahead with the discussion.
Yes, ma'am.
Coming to review of literature, histoplasmosis. Histoplasmosis is a fungal infection caused by a dimorphous fungi, meaning that it exists in the mold form in the environment and assumes a different form, that is yeast form, when it comes in the human body. It is acquired by a pulmonary route via aerosolized microconidia. They reach the terminal bronchiole and alveoli, where they are ingested by the macrophage. Here they are converted to the yeast form and then go to the regional lymph node and the reticuloendothelial systems. In immunocompetent host, there is a limitation. Disease get limited by a granuloma formation. However, if the host is immunocompromised, the infection get disseminated. Clinical features, as already taught, in immunocompetent patient, immunocompetent host, it can be asymptomatic or it can have mild flu-like illness, which is self-limited, or it can present as a pneumonitis or a chronic cavitatory histoplasmosis, or hilar adenopathy with necrosis or with mediastinal fibrosis, upper lobe infiltration, cavitation or pleural thickening, or slowly progressive disseminated disease that clinically resemble tuberculosis. Coming to progressive disseminated histoplasmosis, clinical features include fever along with weight loss, diffuse interstitial and reticulonodular lung infiltrates, hepatosplenomegaly, lymphadenopathy, adrenal insufficiency, oropharyngeal ulceration, and erythematous papules and nodules. Disseminated histoplasmosis severity classification. Severe or moderately severe histoplasmosis is defined as the presence of at least one sign or symptoms involving vital organ, that is respiratory or circulatory failure, neurological signs, renal failure, or coagulation anomalies, along with the WHO performance status greater than 2, that is the person is confined to a bed or chair more than half of the waking hours and only capable of self-limited disease. Whereas mild to moderate histoplasmosis is defined as sign and symptom that do not include the above features defining severity. Diagnostics, it depends on the type of histoplasmosis we are suspecting. In acute pulmonary moderate to severe illness, use infiltrate, we can go for histoplasma antigen. We can go detect antigen in alveolar lavage fluid or serum or urine, or we can go on cytopathology or culture on bile fluid. In chronic cavitatory disease, we can also have option for doing histoplasma serology or fungal culture or microscopic analysis of sputum or bile fluid. In disseminated disease, we can have a serum or a urine antigen, or we can do fungal culture of blood or bone marrow aspirate or any site from where biopsy could be taken. As far as the culture are concerned, they are the gold standard diagnostic test. However, they have a positivity in only 75% of progressive disseminated cases, and fungal staining of cytopathology or biopsy only has sensitivity of 50%. However, we can rely upon histoplasma antigen as they have a good sensitivity that is more than 95% in progressive disseminated histoplasmosis cases. Apart from diagnosis, they are also used for follow-up and for disease progression, and antigen level predict the effective therapy and relapse. Now I'm presenting, this is a case series published in the year 2022 from Mayo Clinic. In 22, there were only 14 cases reported till date, and 2 more cases reported from Mayo Clinic, leading to total 16 cases in the 2020. Out of 16 cases, 11 patients were immunocompromised, where 5 patients don't have any immunocompromised status. Out of 16 patients, the disseminated histoplasmosis was there in 15 cases, and only 1 patient has only limited pulmonary histoplasmosis. Disease outcome, 25% of patient died during the due to disease. However, there is resolution in 75% cases of patient. Out of 16 patients reported, diabetes mellitus was present in 4 cases. Hypercalcemia is a known but rare complication of histoplasmosis, and as I have already told, only 16 cases have been reported till 2020, and after 2020 till date, 4 more cases have been reported, leading to a total number of hypercalcemia associated with histoplasmosis amount leading to 20 cases reported till date. And in this case series, the total serum median calcium was 13.2 mg per deciliter. In this case series, 13 patient PTS level were done. 11 patient had a low level, 1 patient had a low normal, and 1 patient had a elevated level. This 1 patient who had a elevated level is a CKD renal transplant patient. Calcitriol level was reported in 9 of 16 patients. Of these, 15 had abnormally normal levels were within abnormally normal, and 4 patients had high levels of calcitriol. ACE level was done only in 4 of the 16 patients. However, it is found that it is elevated in all the 4 patients. Adrenal gland involvement secondary to histoplasmosis was assessed in 8 patients, of which 6, that is 75% patient had adrenal involvement. In majority of patients, that is 75% patient, hypercalcemia resolved with intravenous fluid with or without bisphosphonate and calcitonin, along with the effective antifungal therapy. Now coming to management, the management guidelines has been last published in year 2007 by Infectious Disease Society of America. They, according to them, for moderately severe to severe disease, liposomal amphotericin B 3 mg per kg daily is recommended for 1 to 2 weeks, followed by oral itraconazole 200 mg 3 times for 3 days, then 200 mg BD for at least 12 months. For mild to moderate disease, itraconazole is 200 mg 3 times for 3 days, and twice daily for 12 months. And they also mentioned that blood levels of itraconazole should be obtained to ensure an adequate drug exposure. And antigen level should be measured during therapy for 12 months after therapy is ended to monitor for relapse. Now this is a article published in NGM in the year 2024. There is slight difference from the guidelines. They recommended that for moderate to severe histoplasmosis, liposomal amphotericin B should be given until improvement. They have not defined a 2-week duration. Learning points. We have also already learned that hypercalcemia is a known but rare complication of histoplasmosis. In patients with granulomatous disorder and hypercalcemia, it is crucial to rule out infectious etiologies before initiating steroids. Treatment with liposomal amphotericin B should be guided by clinical response rather than fixed duration therapy, and drug dosing should be guided by the therapeutic drug monitoring